In 2024, there has been incredible development in the newly diagnosed myeloma transplant-ineligible setting with the development of this quadruplet-based regimen, Isatuximab, Bortezomib, Lenalidomide, Dexamethasone, and how, when we put all these drugs together, we improve the survival of the patient, we improve the depth of the response for the patients, and we do not compromise the quality of life and the safety issues of the patients. That's for sure two studies emerge for registration and benefit as sort of supportive complementary. The thing is that myeloma is not the same disease for all patients. You always have the vast majority of the patients, we usually say 70-80% of the patients that are non-high risk. So very likely to improve, benefit from the treatments and get the best from these new treatments. But you always have a percentage of patients, often 20 to 30% of the patients, that always benefit in a lesser extent. We call that high-risk myeloma. So two things here. Number one, in the past, up to this year, the definition of high-risk multiple myeloma was very much different. It was not completely different, but quite different across studies, across centers, across groups, across countries. And there has been an incredible international effort under the IMS, International Myeloma Society, and the IMF-IMWG groups, International Myeloma Foundation, International Myeloma Working Group, to homogenize the definition, at least one of the high-risk definition, based on the genomic of the tumor cells. And so the new definition is not yet published and in the process of being published, but we thought it would be great to take back our study benefit and to look into with how the high risk performed, but using the new definition. Number one. Number two, benefit is similar to IMROS, a comparison of the quadruplet-based regimen, Isatuximab, Bortezomib, Lenalidomide, Dexamethasone, but instead of using Bortezomib and Dex as one of the standard of care in the control arm, we picked a new standard of care, Daratumumab, Lenalidomide, Dexamethasone, the so-called Maya-like, which historically has provided the best median PFS and results in that population, 65, 80 years old. So we have looked at how the quadruplet that globally beautifully perform in the study, whether they would beautifully perform in high risk, similarly to non-high risk, or only to the non-high risk. And the high risk would again have a benefit, but in a lesser extent to the non-high risk. And we have been using the new definition that I just spoke about. And so the results that we are presenting definitely concluded that in terms of MD, the primary endpoint of benefit, MD negativity rate at 10 to minus 5 by NGS and EF NGS fail by NGF, the primary endpoint was the same. So it's at 18 months at one time point, the high risk benefit to the quadruplet to the same extent as the non-high risk. This is true at 18 at 20 minus 5. This is true at 18 months at 10 to minus 6. This is actually true at 12 months at 10 to minus 5, 10 to minus 6 in complete response and non-complete response MD patients. So this is really, really a good start. We looked at the safety profile across high risk, non-high risk in the two arms, and we found out that the high risk patients actually had the same safety profile than the non-high risk, which again is very important and reassuring. So what we don't know yet for sure is whether that good safety profile, at least similar across the different groups, and the similar great MD impact we've seen will translate smartly and nicely into a prolonged survival and maybe an equally prolonged survival in the non-high risk, similar to the high risk. This we don't know yet. Now, we have reason to believe that the high risk might not do as good as a standard risk in the end, despite the quadruplet, even though we do believe that probably the quadruplet will have improved the high risk, but maybe not rescue this patient and take to this high risk myeloma back the same survival as to the non-high risk. But again, too early to say for that final part. The survival is not mature yet in the study. We have to wait 2 more years to conclude on whether what we have seen in MD will be translated into survival for the high risk, similarly to the non-high risk. In the end, the conclusion is the same. Today, we believe that this Isatuximab Bortezomib Dex is possibly the new standard of care for this newly diagnosed myeloma transplant-ineligible patient, 65-80, maybe 80 plus, but at least 80. And if you're high risk, you should receive that regimen, because the data we have at hand now, though not entirely complete, but the data we have at hand now tend to say that you will benefit as a patient family to this treatment.